A 37 years old right-hand dominant lady was involved in a motor vehicle accident and presented complaining of left-hand pain. She denies any previous history of any injury in the hand, and her past medical history is unremarkable. When you move on to examine the patient, the left ring finger appears to be rotationally malaligned compared with the right hand. She was tendered at palpation over the middle ring finger metacarpal as well as the index of the proximal phalanx. The hand was neurologically intact with 2-point discrimination less than 6 mm. Her skin appeared to be intact without any laceration and had good capillary fill. An X-ray was advised which confirmed fracture of the middle and the ring finger metacarpal and index finger proximal phalanx. The middle finger metacarpal had a long spiral fracture that extended proximally 3/4 diameter length along the metacarpal shaft. The ring finger metacarpal shaft was comminuted. The metacarpal was shortened relative to the normal cascade between the index and the small finger, as evidenced by the relative height of the metacarpal phalangeal joint. The index proximal phalanx was a minimally displaced fracture. Diagnosis of long spiral fracture of the long finger metacarpal shaft, comminuted ring finger extraarticular fracture with rotational malalignment, and minimal to non-displaced fracture of the proximal phalanx shaft was the diagnosis. Regarding the treatment, close reduction of the ring finger metacarpal may be attempted by axial traction and splintage in intrinsic plus position. However, assessment of alignment is difficult once in the splint. Digit heal in a malaligned position resulting in digital overlap, which are not well tolerated, and later on may require osteotomy. If close reduction is chosen to treat metacarpal fracture for malalignment, assessment of the stability of the reduction is of paramount importance. This can be accomplished by evaluating the fracture under fluoroscopy during active movement if a hematoma block or wrist block is utilized as anesthesia, or by using the tenodesis effect of the digit motion during the wrist flexion and extension. Close treatment of metacarpal fractures is indicated for non-displaced or a central isolated fracture shaft. The alignment and the length are supported by the interosseous muscles, which originate from the adjacent metacarpal shaft and intermetacarpal ligaments, which effectively suspend the metacarpal heads through their attachment at the volar plates. This supporting structure usually minimizes the shortening of isolated oblique or spiral metacarpal shaft fractures to a less than 5 mm. Displaced isolated transverse metacarpal fractures can often be close reduced under hematoma block. A cast is utilized for 3 weeks, maintaining empage flexion at 7 degrees, with the proximal and distal interphalangeal joint exposed for active range of motion and passive exercises. Metacarpal phalangeal motion is indicated at 3 weeks with a removable splint for additional 3 weeks. The conservative management of the metacarpal shaft fracture is one of the workhorse of an orthopedic surgeon. But there are indications for surgical intervention of metacarpal shaft fracture. These include multiple metacarpal fractures, especially if they are comminuted oblique or spiral. These configuration would lack any bony or soft tissue support from adjacent digits. Open metacarpal fracture associated with the soft tissue injury or loss of extensor mechanics would be also an indication of operative intervention, because early motion is critical to minimize tendon adhesions and maximize digital motion. Any rotational deformity of the digit is an absolute indication for a surgical intervention. Excessive angulation or shortening is indication for operative intervention, but the amount tolerated depends on the digit involved. The ring and the small finger metacarpals can accommodate greater angulation of the fracture site because motion of the CMC joint is 30 degrees compared with the index and the middle finger CMC joint, which are immobile. Therefore, 20 to 30 degrees of angulation may be accepted in the ring and the small finger, but only 10 to 15 degrees acceptable in the index and the middle finger. Metacarpal shortening is difficult to assess without comparative radiographs. Shortening of 1 centimeter is often reasonable, well tolerated with functionally good results. After operative intervention is determined to be necessary, if the operative intervention is determined necessary, optional internal fixation must be chosen. Isolated transverse or short oblique fractures can be treated satisfactorily with percutaneous spinning. They can be passed retrograde through the metacarpal head as a pin, intramedullary pin, or transversely through the adjacent metacarpal or to add rotational stability. Comminuted or transverse or short oblique fractures may be optionally treated with the plates or screws. Depending on the size of the metacarpal, 2.0, 2.4 or 2.7 mm plate systems can be utilized. A minimum of 4 cortes on either side of the fracture should be engaged. Spiral fractures greater than 2 cortes diameter in length may be treated with interfragmented lax screw. In our case, the middle finger metacarpal is a spiral fracture that can be optimally treated with the lax screw fixation. The ring finger metacarpal is comminuted and may best be treated with the plate and screw system. Surgical exposure of the two adjacent metacarpal was through a longitudinal incision made between the two shafts. Long dorsal sensory nerves are protected and transverse comminuted veins are ligated. The extensor tendons are retracted on either sides. The metacarpal is exposed separately by making a periosteal incision and subperiosteal removal of interosseous muscles and the dorsal metacarpal shaft. It is critical to fully examine the extent and the direction of the metacarpal fractures prior to their reduction. If a screw is drilled through close to the edge of the fracture, it may result in fracture propagation and incompetent screw. Precision is an absolute necessity during the fracture fixation. The spiral fracture was addressed first in our case with multiple lax screw fixation because assessment of reduction is easy to determine. If the comminuted fracture is addressed first, the overall alignment may be difficult to assess because the adjacent digit is already fractured, which may affect its rotational alignment. In addition, anatomical alignment of a comminuted fracture may not be possible. The spiral fracture is separated by cleaning all the soft tissue interposed between the fracture edges. They are then reduced and held positionally with the reduction clamps placed strategically away from the planned screw position. Screw placement should be determined prior to the fracture fixation. In our case, we utilize 2.0 mm and 3 1.5 mm screws. Standard lax screw techniques were utilized, which may be outlined for 2.0 mm screw. First, we drill 1.5 mm drill through both cortices, opening perpendicular to the fracture line to maximize compression across the fracture site. The hole is countersink to minimize prominence of the screw head and maximize contact of the head hole. The screw length is then determined with a depth gauge. Because most screws are self-tapping, we chose screw to be at least 1 to 2 millimeter longer than the measured length to maximize screw purchase in the second cortex. The near cortex is then over-drilled by a 2.0 mm drill to encourage compression at the fracture site. Experience will determine the maximum torque provided by the screw, but more than 2-finger tightness is never necessary. Less torque is often required in orthopedic bones. The plate fixation of a comminuted ring fracture metacarpal was challenging to determine the proper length and alignment. Anatomical reduction of the fracture edges is a goal but often not possible, especially if the long bone loss is severe or the comminution is severe. The first priority is to regain the rotational alignment. Interfragmented screw fixation may initially be used to lessen the number of fragments. Provisional K-wire fixation may be used to assess fracture reduction. Digital alignment is then assessed using Tenody's effect. The digit should be grossly pointed to the scaphoid tubercle at maximum flexion. It may be necessary to compare the alignment with the contralateral hand. The plate is then placed dorsal surface of the metacarpal, and a minor manipulation of the plate may be required as per the metacarpal contour. The plate is held in place with the metacarpal with reduction clamps At time, assistant may help to hold the plate while the screws are placed. The final radiographic appearance is rechecked in the image. The patient is started active range of motion exercise within 48 hours, and at 2 weeks passive range of motion is instituted, with strengthening at 6 weeks time. All the sprints are discontinued at 6 weeks with strengthening exercise encouraged.